Dear Sir or Madam, at the beginning I would like to thank you for an invitation to present the research trial. I feel honored to deliver a lecture on behalf of Dr. Tomasz Zabkowski. This is here, Urology Department, Military Institute of Medicine, Warsaw. I'm presenting the following topic: evaluation of the clinical indications, adverse drug reactions, and finasteride use in patients with diagnosed benign prostatic hyperplasia in Poland. The aim of the study was to evaluate the clinical indications, adverse drug reactions, and finasteride use in patients with diagnosed BPH in Poland. Benign prostatic hyperplasia, also called LUTS or BPH, is one of the most common urinary disorders in elderly men. Histologically, it is related to stromal and glandular epithelial hyperplasia that occurs in the periurethral transition zone of the prostate that surrounds the urethra. The symptoms of the disease include prostate gland enlargement, bladder outlet obstruction, and lower urinary tract symptoms, also called LUTS. The prostate growth is dependent on the presence of hormones and growth factors. Testosterone is considered to be the most important of these, and it is converted within the prostate into the more active metabolite, dihydrotestosterone DHT, by 5-alpha reductase blocker, a nuclear-bound steroid enzyme which is localized primarily in the prostatic stromal cell. Therefore, this cell plays an important role in androgen-dependent prostatic growth. The pathophysiology of clinical BPH is not considered to be dependent on prostate size. Reducing the prostate's volume is thought to decrease the constant component of bladder outlet obstruction. Furthermore, it was shown that men with a prostate volume of 30 centimeters or more have been shown to be 3.5 times more likely to have moderate to severe lower urinary tract symptoms and acute urinary retention. Thus, by actively decreasing the size of the prostate through the reduction of intraprostatic DHT, finasteride plays an insignificant role in the reduction of long-term risk of progression. BPH predisposes patients to bladder infections and bladder stone formation and increases their risk of urinary retention, which in turn causes renal failure. The disease is becoming an important problem of a diagnostic, therapeutic, and socioeconomic nature, considering the increase in the life expectancy of men. Hence, the disease requires surgical treatment. Urination discomfort due to the enlargement of the prostate gland usually appears after 40 years of age and worsens with age. In Poland, approximately 2 million men experience urination discomfort. In 2000, approximately 20,000 patients underwent surgical treatment because of symptomatic BPH. However, over the recent years, the number of surgical interventions performed in pharmacotherapy has significantly reduced because of the increased efficacy of conservative therapy, including combination treatment mostly with two groups of drugs, namely alpha-1 adrenolytics and other 5-alpha reductase blockers with a different pharmacological activity. The alpha-1 adrenolytics provide an improvement within flow rate, but their effects may not decrease the overall risk of BPH-related complications. The 5-alpha reductase blockers inhibit the enzyme which converts testosterone to dihydrotestosterone, the androgen involved in normal and abnormal prostate growth. Finasteride was approved in the United States in 1992 for the treatment of BPH. This competitive inhibitor of 5-alpha reductase type 2 with 10-fold higher affinity than type 1 forms a stable complex with enzyme. It was confirmed that the clinical dose of 5 milligrams per day in human beings decreases the prostate DHT level by 70 to 90%. Furthermore, it results in decreased prostate volume and improved urinary flow rate. The alpha-1 adrenolytics are considered a second group of drugs which is used in combination treatment. They are, for example, alfuzosin, doxazosin, tamsulosin, and terazosin. The noradrenaline acts at alpha-1 adrenergic receptors, alpha-1 AR, in the neck and sphincter of the urinary bladder. It promotes contraction and urinary retention, and it controls the smooth muscles in the prostate capsule and prostate urethra. The selective alpha-1 adrenergic receptors relieve the obstruction by relaxing the smooth muscle in the prostate and bladder neck. Furthermore, they don't affect the detrusor muscle of the bladder wall. So far, the treatment strategies were limited to pharmacotherapy using herbal preparations, Pygeum africanum, saw palmetto extracts, Serenoa repens, or pumpkin seed oil, or to surgical treatment using TURP, transurethral resection of prostate. However, in last decades, it's to observe a progressive pharmacotherapy, which is effective in 80% of patients. Only 20% requires a surgical procedure. Aerial, it was completely different. 80% required a surgical procedure, and in 20% pharmacotherapy was efficient. The clinical trial was conducted from November 2009 to November 2010. A total of 5,751 patients who were enrolled in 46 urological centers in Poland participated in the clinical trial. The researchers who conducted the trial were urologists from different regions of Poland. The clinical trial involved 6 follow-up visits. The most frequently reported discomforts were as follows: frequent urination in 81% of the patients, excessive need to urinate at night, nocturia in 83%, decreased size and strength of the urinary stream in 74%, and beginning of the urge to urinate urgency in 64%. Furthermore, the data on comorbidities were collected, such as hypertension, diabetes, elevated cholesterol and lipid levels, erectile dysfunction, or neurourological diseases. The data, including those self-reported by the patients, were stored in a database for urologists to facilitate the selection of a suitable pharmacotherapy. The pharmacotherapy selected was applied in all the patients. The patients were prescribed finasteride at a dosage of 5 mg per day, owing to BPH and urinary dysfunctions. In addition, the combination therapy of finasteride and other alpha-1 adrenolytics consists of the following: alfuzosin 10 mg per day, doxazosin 4 or 6 mg per day, tamsulosin 0.4 mg per day, and terazosin 10 mg per day. Patients were included in the study if they met the following inclusion criteria: Lutz, age more than 40 years, BPH disease, and finasteride use for at least 2 weeks. The mean age of the patients was 67 years. The clinical trial involved 6 follow-up visits. On the first visit, a self-reported evaluation and physical examination, including a digital rectal examination (DRE), was performed. Furthermore, the urologist recommended that the patients undergo additional examinations, including prostate-specific antigen PSA, serum concentrations, urinary tract ultrasonography USG, with evaluation of residual urine and prostate, total prostate volume TPV, and uroflowmetry. Pharmacotherapy was performed to control the health status of the patients. These examinations were recommended again on the 4th visit after 8 months of treatment. On the succeeding visits, the data pertaining to LUTS were evaluated with regard to the intensification or extenuation of the urinary system symptoms. Furthermore, whether the treatment was continued or changed was noted on the first visit. In addition, the possible adverse effects of pharmacotherapy were also noted. On the second and fourth visits, the results of the additional examinations and DRE were analyzed. Based on the results of the physical examination, BPH occurred concurrent with other diseases such as hypertension in 50% of the patients, diabetes in 26%, elevated levels of cholesterol and lipids in 28%, erectile dysfunction in 29% of patients, neurourological diseases such as Parkinson's disease and multiple sclerosis in 6% of patients, and others in 5%. In addition to the administration of finasteride at a dosage of 5 milligrams per day in about 6,000 of patients, the combination drug therapy consisting finasteride plus alpha-1 adrenolytics was also administered. The combination drug therapy was inclusively prescribed to about 70% of the patients, including 31%, 29%, 4.6%, and 1.5% of the patients receiving tamsulosin, doxazosin, alfuzosin, and terazosin respectively. On the second visit, extenuation of LUTS BPH symptoms was observed in 53% of the patients. The improvement was most common in the spectrum of the following symptoms: frequent urination, 52%, excessive need to urinate at night, 53%, decreased size and strength of the urinary stream, 43%, and beginning of the urge to urinate, urgency, 42%. Adverse effects were observed in more than 30% of the patients, such as those with erectile dysfunction, 31%, low libido, 32%, low ejaculation, 16%, enlargement and pain in mammary glands, 3.7%, pain and dizziness in 9%, and orthostatic hypotension, 2.46%. The results of the following prescribed examinations were analyzed: PSA, urinary tract USG with evaluation of residual urine and prostate, and uroflowmetry with the evaluation of maximal flow rate. In this clinical trial, on the second to the sixth visits, progressive improvement in the spectrum of LUTS symptoms was observed as self-reported by the patients. The conducted McNemers test has shown a significant difference in improvement in the spectrum of Lutz symptoms on the second and on the sixth visit. The prevalence of adverse effects after pharmacotherapy was also evaluated. The conducted test students test during the analysis of received data has shown a significant difference in total amount of adverse effects reported by patients on the second and on the sixth visit. On the fourth visit, after the 8-month treatment, the urologist recommended repeated diagnostic examinations. The clinical trial was completed after the sixth visit. The data on urological symptoms were analyzed on the last visit. In this figure, data showing the noticeable decrease of the Lutz and extenuation of adverse effects owing to the efficiency of the pharmacotherapy are presented. In our medical trial, we confirmed the efficacy of finasteride administered to patients with extensive Lutz related to Lutz BPH. Finasteride was demonstrated to be effective as evidenced by the significant decrease in TPV by 40% even after 12 months. It was also found to contribute to the attenuation of Lutz, improvement in maximum flow rate, decrease in nocturia, and improvement in quality of life. The combination therapy was more efficient as placebo and monotherapy of alpha-1 adrenolytics or finasteride monotherapy in the suppression of BPH progression. Thank you for paying attention. If you have any questions, please contact with the author, Tomasz Zabkowski. Yeah.
Just one question, a very simple one. If nobody else wants to ask. The first question is, what was the effect of finasteride on the residual volume and prostate size?
On the second visit?
Any visit. After the sixth visit.
The shown of this the data of this aren't shown here, but also the residual urine was smaller, and prostata enlargement. What do you say?
Prostate size.
Is also prostate size was also smaller on second and then on fourth visit.
Any percentage which you can say percentage reduction?
We haven't.
But for example, if a patient had a pre-therapy residual urine of 60 ml, and how much it became after the sixth visit? Suppose one patient had 60 ml when he started therapy. Then after 6 visits, how much was the reduction? From 60 to 20, 10?
From, for example, from 60 ml to 30 or 20.
Okay, so it was about 70.
It was median, to 20 to 30.
And the prostate size?
Prostate size was decreased by about 30%.
Which classification did you use? Classification for the grade. This was all grade 3 BPH or grade 2?
3 BPH.
All 3?
All 3.
Okay, fine. Thank you.
Thank you so much.
So I have a question quickly. It's quite interesting, first of all, these 6 different ADRs that we've got here. The first 3 it just jump out at me as being, they would be very common in the general population. Not very common, but they would be more common in the population of males over 40 anyway, generally speaking. Because there's a huge difference between the first 3 and the lower 3 in terms of percentage-wise. which is interesting, but that could be due to background incidents as well. But I'm also looking at how it decreases over between the second visit and the sixth visit. We've got a decrease in erectile dysfunction from 31.5% to 14.3%. Is that an improvement over the time, or did we have a number of patients that dropped out of the study?
It is always improvement.
It's always improvement.
Yeah.
No, but these are adverse drug reactions. So the number of adverse drug reactions at visit 6 appears to be lower than at visit 2.
Here's shown that on the second visit, erectile dysfunction was
31.5%.
in 108 1,800 patients, and on the last visit, on the sixth visit, only 800 patients.
Okay, that's at the end. Sorry.
Yeah.
After the sixth visit, yes.
Yeah, it's end.
So patients have
Yeah.
reduced in number. Yeah. Okay, that's fine.
Thank you.